I'm going to welcome back Dr. Oller, who's a primary care and addiction medicine physician. He's an associate program director for the University of Kentucky, internal medicine residency program, and an investigator for the Healing Community Study. Welcome back, Dr. Oller.
I don't have any financial disclosure. What I hope to do over the next hour or so is review a little bit of the framework and some of the key talking points that we went over last week, but mostly jump into some of the questions that you all had and some sort of cases or scenarios that you might see either in your peer support work or care navigation work. And we have some pharmacy and clinician colleagues here as well. So let's jump into it. So last week we talked about having this framework for really all types of chronic pain. And from clinicians, these are the things that we focus on. And so you can also help your clients focus on these things as well as they're preparing for their doctor's visits. So it's the mnemonic TLC. So talk about it, focus on loss of function, and collaborate. So when we say talk about it, we really want to make sure that that client, that patient that you're working with doesn't feel alone, that many people are dealing with chronic pain, that there are significant chronic pain support groups around the country in the same way that there's AA, NA, Smart Recovery, and other recovery focus groups as well. We want to make sure that we're identifying those key areas, those key domains of life where pain is getting in the way of what they want to be doing, because that centers that discussion on interventions that are going to be helpful for those specific functions, rather than just gearing the discussion towards how to move a pain score from 10 to 9. We are really focusing on how to give this person more control back, more of their life back. And then lastly, collaborate, understanding that many times our conversations around pain management break down when we're not understanding, when we're not listening to the person across the table from us. And we can do a lot better when it comes to collaborating with clients when it comes to controlling their pain. We talked a little bit about pain categories, how there's this nociceptive type of pain, really an inflammation type of pain where tissue is damaged, it's inflamed, and that sends pain signals to the brain. And that's everything from kidney stones to arthritis of your knee to the chest pain that we get when we're having a heart attack or we have limited blood flow going to the heart. But there's also this neuropathic pain where there's damage to the actual nerves or the central nervous system. And so pain signaling is altered in a major way. And then finally, there's neuroplastic pain. And these are often tougher to treat conditions, from fibromyalgia to bladder pain syndrome to irritable bowel syndrome, where we know that there's something going on within the body, but the pain signaling is super altered. And in addition to identifying sort of what might be causing some of the issues at the tissue level, often we're forced to step back and say, hey, can we alter that pain signaling and give people back a little bit more control in their life? The reality is that as chronic pain develops, there's this centralized pathway involving the glial cells in the central nervous system where folks are sensitized to pain. They have more pain from a flare and inflammation than somebody who is not dealing with chronic pain. And so there's this crossover effect where even if the original insult was just at the tissue level or from inflammation, tends to then cause this change in pain signaling over time. We also know that there's disparities in pain management, both in terms of the background of patients coming into care, as well as the comorbidities that they might have, including opioid and other substance use disorders. We know from prior studies in the emergency room that non-white patients are less likely to receive opioids, even when those are indicated for acute condition in the ED, that Hispanic patients are less likely to receive opioids than non-Hispanic patients in primary care settings. And that sometimes when learners are involved, residents or medical students or others, that patient might be less likely to receive higher dose prescriptions than others. And there's a fine balance here, right? Not every painful condition has a clear indication for opioid therapy, but some acute and chronic pain, it's certainly indicated. And so we don't want to be depriving our patients of improved functioning because of our own implicit biases. And then we talked a little bit before about how we often get stuck in these conversations around pain in the clinical setting. And the reasons we get stuck are multifold, but if I were to break it down into a couple of important buckets, there's not understanding, there's misunderstanding, and there's disagreeing. Not understanding, these are situations where you really want to make sure that you're advising clients to potentially seek other opinions, to seek additional support or help, because we're not getting anywhere. The clinician might make an unwarranted assumption about what they're saying or doing or meaning, and there's a clear disconnect in terms of the communication that's happening. Misunderstanding is really where the clinician or the patient is taking cues, whether they're verbal, whether they're nonverbal, from the person on the other side of the exam room table, and not quite understanding or misinterpreting what that person is trying to convey. So example might be sort of a puzzled look, or phrases like, I don't get it, right? And I don't get it might be, I don't get it in terms of what's happening physiologically in their body, or I don't get it in terms of a suggestion for managing pain that maybe they tried already or didn't see an impact from in the past. And disagreeing occurs when you have pretty similar and symmetric information between two people, but you're not settling on a clear way forward. And again, this isn't necessarily a reason to bail and leave that relationship, but it is an opportunity to step back and say, and really try to verbalize out loud. It seems like we're just sort of disagreeing on this, and I'm not sure the best way forward on that, but maybe let's think about switching gears and talking about something different, or a different aspect of my pain that maybe hasn't been addressed. And throughout, the way that we avoid all of these is that genuine interest, that empathy and curiosity to try to understand where people are coming from. I talked a little bit last week about buprenorphine and methadone for opioid use disorder in patients who are experiencing chronic pain. And like we talked about before, both were developed prior to their use in opioid use disorder for pain. In fact, they've been around for decades prior to being used to treat opioid addiction. And with good outcomes, both short and medium term in terms of pain control. Usually they were dosed in sort of split dosing, so dosed multiple times per day rather than once a day, as we typically see in the treatment of opioid use disorder, because of the specific analgesic or pain acting properties of these medications being limited to a few hours after they're dosed. And full agonist medications do not provide superior outcomes in managing pain compared to partial agonists. So in somebody who is well controlled in terms of pain and cravings on their therapy, be it buprenorphine or methadone, in the chronic pain setting, we want to make sure that folks are staying on that as long as it's working for them. Okay. Let's jump into some of the questions. So this is a big one that I hear a lot of time, and there's a lot of fear around this question too, from clients as well as clinicians. That is, does being on buprenorphine, methadone, or naltrexone make treating pain harder? So let's go back to really what's happening at the receptor level for opioids. And I think this is helpful because you can explain to clients sort of what's happening in their brain, why they feel the way that they do, and how it gets better, right? So certainly an antagonist like naltrexone, the more you increase the dose of the naltrexone, it's just a blocker. So it's not having any effect on pain unless other opioid medications are coming into the picture, in which case it's blocking it. So in folks who are on extended release naltrexone for opioid use disorder, or Vivitrol is the brand name, then we do have to forewarn them that if they're in an acute pain situation, so they're in a motor vehicle accident, or they fall and break a bone, they may have to get medications that are not opioids to help control their pain, because that blockade may not be able to be overcome with even very potent opioids. But when you think about buprenorphine or methadone, for most patients, as they are on buprenorphine or methadone for a longer period of time, their body is used to that level of activation at the mu opioid receptor. So for buprenorphine, it's about halfway up that graph. For methadone, it may be even further up that graph. And what happens in the acute setting is that there's this tendency to say, because these medications are on board and they're occupying some of those opioid receptors, we need to sort of clear the body of those medications before pain is being treated. And actually the opposite is true. When we stop those medications, we have a huge hill to climb just to get back to how they were feeling before they even came into the hospital or the clinic or the emergency room. We have to overcome that gap between the bottom of this graph and that blue line, or the bottom of this graph and that green line, with full opioid agonists before we even start to get pain control. So one really important thing is emphasizing with your clients, if you're going in for a procedure or surgery or something like that, the best practice is in most cases not to stop the medication, because we're going to have such a hard time sort of filling in that gap and overcoming that deficit in opioid agonism at the mu receptor. That's point number one. But the other point that I'll make, and why it's important to emphasize this with clients, is that we have this decent literature or collection of literature on both buprenorphine and methadone for the management of chronic pain, separate from opioid use disorder. So this was looking at specifically transdermal or TDS buprenorphine. And so those are buprenorphine patches that are right now only approved for the treatment of chronic pain. And it found that was effective in a wide range of chronic pain disorders. However, there's really not a ton of studies looking at the sublingual or the IV formulation of buprenorphine for the treatment of chronic pain. So we need more studies looking at that. But what this seems to suggest is that buprenorphine can be used effectively to manage chronic pain in patients without opioid use disorder. And those patients with opioid use disorder are dealing with often similar pain conditions than folks without opioid use disorder. And so we should be able to use buprenorphine to help with their pain. And that's similar for methadone. So this graph can be a little bit confusing, but methadone is in the sort of lighter blue or teal colored dots, and morphine is in the orange colored dots. And it's looking out from time from the first appointment that a patient has to 360 days or a year out. So this is really talking about chronic pain patients, and whether they're on morphine, oral morphine, or oral methadone to help manage their pain, and their worst pain score, right? So that worst pain score goes from 0 to 10 over the course of the week. And you see that many patients, even on these medications, have fairly high pain scores, but there's no significant difference. There's no major separation of those curves for methadone versus morphine. So while we think of methadone as sort of a weaker binding at that opioid receptor, It is still a very good medication to help manage pain. It hits other receptors that modulate the pain signal, and that's another big reason why it can be helpful for pain. Um, and it seems to be no different from morphine in terms of minimizing some of those worse pain scores over the course of the follow-up that patients are having in clinic. But the major barrier that we see again and again and again when it comes to managing folks with chronic pain and opioid use disorder is stigma, right? We see reluctance among clinicians in using full opioid agonists in patients who have an opioid use disorder or even a remote history of opioid use disorder, out of fear, usually from a regulatory or legal standpoint, that they might get into trouble, right? If they're prescribing this to somebody who might have an active addiction. When the reality is that with close follow-up and guidance, that patient can be safely treated with those medications. And so there's a few things that I would recommend that you focus on with your clients, or if you're somebody experiencing chronic pain when you're talking with clinicians, to make sure that we're asking them about. So one is, if this plan doesn't work, what will be our next step to control my pain? That's really important, right? We know that a good chunk of time, even our best medications, say for depression, work about a third to half of the time. And chronic pain medications are effective at even a lower rate than that. So it's at least a coin flip's chance, and maybe even higher, that what is initially started or what is initially tried is not going to be effective in returning some of that function and improving some of those domains of life that are important to somebody living with chronic pain. So ask up front, what will be the next step to control my pain? Another great question is, how long should I wait before contacting you if I'm not seeing improvement? So there's several medications for pain that might take a while to get to effective dose in the body, right? Or it may take some time to creep up on the dose to minimize side effects and optimize benefits for somebody living with chronic pain. I think about some of our nerve pain medications like gabapentin or Lyrica, or pregabalin is the generic name for that. That can take time to find a dose that is effective in controlling nerve type pain. And so you want to be asking your clinician, how long should I wait if I'm not feeling a response to contact your office, right? To make sure that you know whether or not this is working. And then how would you like me to document my response to this plan, right? Sometimes it's helpful to keep a weekly diary of how our pain scores are looking, or what specific things are improving, what things are not improving. Sometimes even just writing down what a typical day looks like can be really elucidating for a clinician trying to figure out what might be helpful for a patient. So I think all of these questions are really good. If you or somebody you know or are working with has opioid use disorder and chronic pain, and wants to really get the most out of that initial appointment with a pain management or a primary care doctor, these are some things to focus on. What are treatment options for patients or clients that don't want to use opioids? So I think this question comes out a lot of time in folks in the acute pain setting, less so in the chronic pain setting, but I'll try to touch on both. So in the acute pain management setting, we mentioned earlier for folks who are on extended release naltrexone, it's likely that that opioid medications are not going to be effective because of that strong blockade at the opioid receptor. Whereas somebody getting buprenorphine or methadone, binding is still fairly dynamic at those opioid receptors. Not all the opioid receptors are occupied by methadone or buprenorphine. And so using potent full opioid agonists can be helpful in managing pain in the acute setting. But sometimes that's not an option, right? And that's where we think about some other things. So And ketamine is an older drug, but a newer thing that's being trialed to help manage acute pain. It's actually a dissociative, and so one of the main side effects is sort of thoughts or experiences that are a little bit odd. Or not usual for people, but it is helpful in sort of modulating that pain signal, and is very fast acting, and so can come on pretty quickly to relieve pain. So somebody in a car accident who's on Vivitrol, this might be something that's given even in the emergency vehicle coming into the emergency room. There are a lot of other acute options. I think nerve blocks are one thing to think about especially for fractures, and are given pretty regularly by pain management or anesthesia teams. And that can be localized or a central nerve block. Steroids. There's a few conditions that are very responsive to steroids. Or NSAIDs, so ibuprofen, or as well as Tylenol. But again, depending on the severity of pain and the condition, those agents might not be effective. And then neuropathic pain medications, thinking about gabapentin or pregabalin. But the problem with those is that, as we talked about before, it can take a little bit of time to get to an effective dose. And so for those first few days, it may be that somebody's struggling a little bit more with pain and needs additional medication besides the neuropathic pain medication. There's some decent evidence around acupuncture for acute lower back pain or chronic lower back pain as well. And so if that's available, that's something to think about as well. But sometimes we're seeing that clients or patients are not interested in managing their acute pain or even their chronic pain with opioids because of fear about how it might jeopardize their recovery or their remission of opioid use disorder. So if that major concern is a return to use, I think it's important to ask the question of, will untreated pain or exposure over a limited amount of time to an opioid agonist actually be a greater risk to your recovery? And I think for many patients, that untreated pain is often a greater risk. And so having a backup plan to deal with things. So I'm going to say, give this 24 or 48 hours. And if things are not where they need to be, then I'm more comfortable with maybe receiving morphine or Dilaudid or something else to help with my acute pain. You want to work with the clients, or if you yourself are the person going through this, with the clinicians to understand sort of how long you should anticipate dealing with the pain. Is this something that most people see sort of decrescendo or decrease in their pain over the course of a couple of days? Does it take a few weeks to heal from this? When does that peak inflammation sort of begin coming down? Getting an idea of the timeline or how long you're going to have to deal with the pain can also help you decide on that backup plan, as well as reaching out for additional help, right? And if you're feeling like pain is not controlled, or you're trying to advocate for a client whose pain is not controlled, I think sharing something like, I appreciate what you're trying to do for this person. I just want to make sure that we're not missing anything that could help them out, right? So asking to see a pain specialist or addiction specialist, if that hospital has one, to try to get some input. When clients or patients are on Medicaid, does that limit some of their treatment options? So when thinking about specifically chronic pain management and being seen in a pain management clinic, most consultations are covered by Medicaid. However, the procedures that are usually offered through pain management, things like nerve blocks, injections, spinal cord stimulators, and other therapies, often those are procedures that require several hurdles to jump through to be able to get it covered under Medicaid, and even some private insurances as well. So they might want to see that other therapies were trialed. or that there were failure of other therapies, or that we've run out of other options to offer at this point. And that gets back to what we were talking about before of really asking the clinician, asking the person that you're working with, how are you documenting sort of, or how should I document my response to this, right? When should I tell you if something is not working or I'm not seeing improvement? Because that way you're starting to share that information that might be able to be assembled into an argument for the insurer that really additional things need to be tried to get some more comfort and get some more control into your life. I think the other thing that folks run into is they may ask people to come in fairly frequently for office visits, and so those copays can certainly add up as well. So I think there's a lot of room in terms of expanded access that needs to happen for our Medicaid patients when it comes to pain management. Access not just to get in the door at pain management services, but also to get the therapies that they need. And many times there's multiple hurdles that have to be jumped through. I'll also add that for folks who that buprenorphine may be the most appropriate treatment for, I have really struggled to get that covered just for chronic pain. It often requires a prior authorization and appeal once that prior authorization is denied, when folks are just getting that for chronic pain. When folks have an existing opioid use disorder, we can use some of the sublingual formulations and tend to get those covered. Even if that opioid use disorder is somewhat remote, often I'll frame it in my notes and my documentation that pain remains a major trigger for a potential return to use. And so we're using this both as a relapse prevention strategy and to try to manage their pain better. Medicare and copays. So we had issues with that in wave one. Whitney, do you mind going off mute and sharing a little bit more, or maybe like a de-identified case that might illustrate what you're running into, so I can try to be specific in my response?
In wave one, I had some clients that had Medicare, and I would say all of them had chronic pain. So they ran into having copays like at the outpatient clinics, and their copays would be so high, they couldn't pay them. So they would end up being like tapered off or discharged. And also it's hard for them to get case management services because they can't get billed. And counseling services are also kind of hard for them to get with Medicare.
Yeah, and in many of those cases, there's not much within sort of that Medicare plan that can be done, but in some cases, if they also have a significant disability, or they're under a certain income amount, they may also qualify or be dual eligible for Medicaid, right? And so that might be something that you work with the client and using and leaning on the Medicaid portion of their coverage for some of those things. I think we also run into issues with Medicare covering Sublocade, the extended release buprenorphine product, which is highly effective for a lot of our patients and actually achieves a higher plasma level in the blood than sublingual buprenorphine, even at 24 milligrams a day. But Medicare, we've run into major issues trying to get that covered. So again, I think working with the client, trying to see if there's other, if they are dual eligible for Medicaid, but I wish I had a better solution for those folks as well. Matt L., I have a question about prescribing approved bup products for pain. Yeah, go ahead, Matt.
So
can I answer for?
I'm on board with the remote opiate use disorder and using buprenorphine to treat that, right? A lot of providers, especially ones that aren't incredibly comfortable either with the laws in the state or buprenorphine, probably are not going to go that route. My understanding of the state laws around prescribing is that you're allowed to prescribe FDA approved products to treat pain. You're not allowed to prescribe FDA product things that, so like for instance, you technically can't prescribe Suboxone to treat pain because it's not FDA approved for that, unless you're a hospice palliative doctor, and then they have a carve out in the Kentucky Medical Board Association that allows you to do that. Is that an accurate statement?
So yeah, so that specific product, buprenorphine, naloxone, or Suboxone, yes. Some of the other formulations like the transdermal or the buccal buprenorphine products that are approved for pain, those are ones that you can prescribe to patients with comorbid pain and opioid use disorder.
So how do those either the buccal or the I think there's an injectable that's been approved as well. Like how do those medications work to treat OUD comparative to say the sublingual medications and the dosage that you would give somebody to treat pain? So let's say I'm truly just treating pain, and that's what I'm using the Butte for in one patient. Would it be what would be a chief analgesia for patient A that doesn't have an OUD, right? Would that same dose that achieves analgesia patient B also be enough to treat their opiate use disorder, or might you find that you need more than what you would typically use to treat analgesia to also cover cravings, withdrawals, all that whole piece? What does that look like? And I feel like and I ask that because I really feel like there needs to be more education for prescribers, because working in the hospital system, I don't see buprenorphine prescribed enough for OUD, and it certainly doesn't get prescribed for pain unless like a hospice or a palliative doctor's on board. And so we have people who leave the hospital who truly need, they really would be better off with Butte for pain, but they're not getting it. So just kind of interested to see what your thoughts are on that, and what dosing looks like from the perspective of treating achieving analgesia comparative to actually managing an OUD.
Yeah, so this question really illustrates all the different twists and turns and convolutions within licensing and regulations that we have to go through, right? It shouldn't be this hard, right? But I think a couple of important things to point out. The reason that there are some formulations that are approved for pain and some formulations that are approved for opioid use disorder is because there were studies, randomized controlled trials with that specific product in that specific population, right? So what we see is that in patients who, if you look back at those studies of patients receiving buprenorphine for pain, they were using pretty low doses. So the equivalent of between sort of 2 and 8 milligrams of sublingual bupe. That's what they were getting. And sometimes the patches come in even lower formulations. And the main reason that is oftentimes they're being used in folks who are opioid naive, right? And we forget that buprenorphine, while it is a partial agonist, is a very potent partial agonist and can cause significant sedation in folks who are totally naive, right? So the first answer is that the pain dose is usually significantly smaller than the dose that is being used in opioid use disorder for buprenorphine products. And for that reason, oftentimes people with that history of opioid use disorder, if we put them on sort of those lower doses, they don't notice much of an effect when it comes to pain. And so often we're trying to justify the use of that medication to try to promote ongoing long-term recovery and remission of their opioid use disorder rather than pain specifically. Methadone. Methadone, there's a legal requirement that we cannot prescribe from a clinic setting, not a methadone clinic, but a primary care setting. We cannot prescribe methadone for opioid use disorders against the law, right? And that's important for everyone to hear, right? So, and the dose of methadone that we use for chronic pain is again typically lower than that goal 60 to 100 milligrams that we're aiming for when somebody is going to opioid treatment program. And that's again because usually somebody is more opioid naive, who is being started on methadone for chronic pain than somebody who is injecting, say, a gram of, or plus a day of fentanyl, where that opioid tolerance is super high. Where there needs to be more clarity in terms of regulation, and what would allow, I think, more clinicians, more providers to feel comfortable managing this, is if they went out and clearly stated, rather than just sort of implied, that opioid use disorder is potentially a chronic disease that requires management occasionally, even for folks who are on long-term remission. And so that's really where we need to see some improvement and some advocacy. Hopefully that answers most of the components of your question, Matt.
It does, and I think what you bring up really brings kind of the area that we have an issue with some Kentucky regulations around opiate use disorder and medications to treat. A lot of states will allow you to treat off-label. So, I could use, not me, but a prescriber could use Suboxone off-label to treat pain, the way that Kentucky has it that you can't. And in Louisville, it's not that big of a deal. I can find somebody who is boarded to treat pain, treat addiction medicine, and we can make it work out. I think it really becomes challenging, and how do you help people navigate it? For somebody who lives in a more rural area, they don't have a provider that is comfortable or really knowledgeable in using, buprenorphine to treat pain. And so then they end up at a clinic where they're now in a situation where, say, they're getting 16 milligrams a day, and the clinic can't, prescribe a BID or TID, because that's not how you take medication for an opiate use disorder. And then we're putting a person in a situation where we're telling them, officially, you take this once a day, but then the doctor is saying, off book, well, I know you have pain, so what I want you to do is split it up. And so we're saying one thing in the medical record and another thing verbally, which I don't think is really healthy for the provider or the patient, or we're putting the patient in the position where they have to dose their medication in a way other than it's prescribed, which has the potential to bring back some old habits that aren't necessarily good. And that for me is really, in this conversation, the concerning piece is for our patients that are living in more rural areas where there's less access. Yep. People really don't get appropriate pain coverage or pain treatment with their medication within the confines of the law, and really have to step outside of what is deemed as appropriate by our regs. And I think that's challenging for recovery, to say the least.
I think that really encapsulates all the challenges that we face on both sides, the patient sides and the clinician side, in terms of managing this population. And specifically, I think while some telehealth and a lot of what our navigators are doing in terms of helping with transportation, that's a huge help in lowering some of these barriers. But the main barrier that's going to continue to exist is stigma that is derived from both regulations and the training and education that clinicians receive, and the sheer paucity of clinicians who feel comfortable managing this as a result of that stigma. All right. Just in interest of time, I'd like to move on so that we're able to get to some cases and a little bit more dialogue with the whole crew here. But what should I do if I feel that a client is not getting adequate treatment because of their opioid use disorder? So, to no surprise to any of our audience today, this is extremely common. I pulled some quotes here from a couple qualitative studies. One looking at patients with opioid use disorder in rural settings, and another looking at patients who were hospitalized with endocarditis or infection of the heart valve. And as much as I read this, as much as I've unfortunately seen this, it still is nonetheless shocking to hear something like this, where she's just asking, for something to ease the pain so it could lay down and take a test that was necessary for, in this case, to diagnose the endocarditis, and they wouldn't give me anything. The next thing is, I was so mad I couldn't take that test, right? And so people are quote unquote refusing care when in reality, if this patient didn't have a history of opioid use disorder, a medication would be provided to make that test more comfortable. Or this one below is even more shocking. Of, the nurse told me I did not need any pain medication during labor because I was on Suboxone and was a drug addict. The way that she treated me made me feel like a piece of blank, and that's not right, right? And yes, our options are somewhat limited when it comes to pain treatment in the setting of pregnant patients because of interactions in some of these drugs crossing the placenta. But geez, we have to be doing better, right, than this. So I welcome other ideas, but let me just sort of start by saying what I often coach my clients to say when they're going into an environment or a situation where they might run up against stigma around managing their pain. So my go-to is to tell them to say this to their doctors, to say, this may not be something that you're used to seeing or managing, and I know it can be a challenge. I'm wondering if there is addiction medicine or palliative care or a pain management expert that can weigh in on the best next steps, right? It's basically asking for that team to grow, to hopefully include people who are more understanding of what that client might be going through and could better be able to help them. But what other ideas do people have when in terms of advocating either for yourself or for a client when they're in a situation like this? You can either unmute or jump into the chat.
So for me, it's threefold. If I have a relationship with the physician, I'll just contact the physician directly, especially within the hospital system, and have a conversation with them about it. If I have concerns, if the physician isn't responsive within the confines of our hospital system, I'll file a formal complaint. We do that, like the patient safety reporting and going through a peer review board process. And if it's outside of the hospital system and I believe a physician is practicing in a way that's discriminatory, I file a complaint with the Kentucky Medical Association, their board. Or if they work for an organization directly with their organization, I file a complaint with the organization and with their licensing board as well. And I think we have I would say from my perspective, we have an ethical responsibility when we see a person being treated inappropriately, to file those complaints, because it's poor practice and the risk of the negative outcome for our patient is pretty high.
I think we had a raised hand. Thanks for sharing. Go ahead, whoever raised their hand.
Hi, I hope you guys can hear me better. This is Christy, and I'm going to use myself as an example. And so I was actually in a treatment hospital here locally, and I was prescribed and had been on Xanax for my anxiety for over 10 years. And my neuropsych and neurologist that prescribed it, I've never had any problems with that. But
right,
I can be honest that once I got a hold of dealing with my anxiety, of being the root problem, it helped me to stay in recovery. And so at the facility, they wanted to deny me my Xanax while I was there, but I had to advocate and even explain to them that I've never had a negative test. You can check with my other doctors who have been my physicians, but it happens a lot. And I would just say, as a recovery coach, I plan on not only advocating for my clients and participants, but also teaching them things that I learned where they can advocate for themselves and hope that it gets better throughout the state.
Yeah, I love that idea of here's a doctor, here's a professional that knows me better and knows why this is important that I continue this. Please talk with them, right? I think somebody has to be very callous and uncaring to not pick up the phone and try to figure out what might be helpful for their patient. So I think that's a great suggestion. Any other suggestions?
It's Jenny.
Go ahead.
One thing, so like I've dealt with chronic pain for most of my life. Like actually, 2022 I had back surgery. So I know being someone with OUD, like it's hard to always trust your patients, but you know, like sometimes even listening to just them on what works, you know, like you were
Hmm.
talking about like gabapentin and things for like nerve damage. But like I had actually found that I didn't like that medication. I didn't like how it felt. It didn't really work. But
Right.
I was put on anxiety medication for a short period last year, and that medication actually worked better for my nerve pain. But when you walk into a doctor's office or anywhere and you're like, hey, this medicine works and this one doesn't, they always kind of get that assumption like, oh, well, she's trying to seek this certain thing or she's trying to do this to get something else.
Right. And so I think I respond well, and I want to acknowledge that I think it usually goes best when um, there's that direct, not just sort of papers sent the way of the new provider that you're seeing, but a one-to-one warm handoff from your prior treater to that new treater of this is what works, this is what we've tried, and this is where to really focus on continuing to improve her functioning, right? So I think all of these are really great suggestions, guys, and come from a place of that personal experience, and the literal pain of having to deal with systems that are sometimes unfortunately uncaring of these issues. I'm just going to clear my drawings here. Okay, let's keep on going, because I had some cases that I want to go over with you guys. And so for each of these, I wanted you to think about and maybe write in the chat if you want to sort of one question that you would want to ask the client or the patient that you're working with here, and sort of one suggestion that you might have in helping them manage their pain. And if you don't know, that's okay. We'll talk about some things that might be helpful for them. So starting out here, this is more of an acute pain case, but I think still something that's important to go over in our population that we work with. So AD is a 30-year-old female with opioid use disorder receiving Sublocade, so extended release buprenorphine, is admitted with a clot in her leg that's requiring emergency surgery. After surgery, she's struggling with pain control. So what's sort of one question that you would want to ask the patient, and maybe one suggestion that you might have for helping them manage their pain? And while you guys are thinking through that, I just want to acknowledge Elizabeth's really great remark in the chat that often going through primary care, working with a specialist is the best way to get treated with respect, and going to the emergency room can sometimes re-traumatize somebody who's been through a lot in recovery. And I think that that's true. And I think, though, that it doesn't excuse our primary care and specialist colleagues, of which I'm one, right, to try to do better and make that environment even more inviting for folks and easier to access. But what are some ideas about this case? What are some things that we might want to ask them, or suggestions that we might have for managing their pain? So maybe just asking their group a yes or no question. Do you think this is a patient that should be receiving sort of quick acting, strong opioid medications right now? So Jenny says, what medications have you received in the past that have helped? Yeah, what strategies have worked with you in the past? So I think it's great, right? To start the conversation from what's helped in the past, right? In this situation where unless by some really bad luck she's had this emergency surgery before, she may not have experienced similar pain in the past, right? So we might be working in sort of a black box here. So even just starting with what are you feeling right now? How are you dealing with this right now is good. But I think and gain an idea sort of how the medication for opioid use disorder is going. Pain scale. So even though it's shown not always to be helpful in managing sort of acute pain like this. Sometimes it's the thing that other clinicians are most responsive to, right? So getting some of that data can be really helpful. I would also just ask the client, what are they fearing right now, right? Both about this pain or about the medications that we might use to control pain, right? So this might be somebody who really, really, really does not want to use other opioids in this acute setting because of fears about a return to use or it triggering a return to use. And so we can revisit that question that I mentioned before of, do we feel like it's a bigger risk to have your pain untreated versus being exposed over a short period of time to a medication that caused some problems in the past? Okay, but I'll tell you, we're increasingly seeing folks with sublocade who are dealing with more acute pain issues. And we have seen some success in using full opioid agonists or things like morphine, Dilaudid on top of the sublocade to provide some relief. Because while most of those opioid receptors are occupied by buprenorphine, some are still open, the binding is still dynamic. We may need to use higher doses or more frequent doses, including sort of a patient-controlled analgesia or PCA pump can sometimes be helpful in these cases, but we can get that pain under decent control. Okay, case 2. So BC is a 45-year-old male with opioid use disorder and chronic pain following a motor vehicle accident that resulted in several issues with his back. So he's been dealing with back pain for decades. He takes buprenorphine 16 milligrams per day. He reports struggling a lot with pain and asks if there are other options that could help him. So again, one question that you would have and maybe one suggestion that you might have for managing his pain. So some of these same ones that you guys had listed before are helpful, right? So what have you taken before? What's been working best? How are you dealing with the pain now? If we remember back to our TLC acronym, T is talk, right? So talk about that pain, what it feels like to them, what that experience is like, what sort of category of pain are they dealing with, the fact that they're not alone, the fact that we sometimes do a bad job of managing opioid use disorder and chronic pain. But that doesn't excuse the fact that you're in this pain and we need to try to develop a plan together. But the L of TLC, right, is the loss of function, right? So focusing on loss of function. So we really need to know sort of what is his pain getting in the way of, right? Is it sleep that's affected by his pain? Is it mobility issues? Is it affecting his work? And the reality is that it's probably all of the above, but there may be a few priority domains, work or sleep, that we can provide some suggestions for to address those specific domains and loss of function. And so I think these are really good questions that you have. What are some things that we could do to maybe help with this pain a little bit more? So Stacy mentions physical therapy, and last week we went over an article that described how people living with opioid use disorder were both less likely to be referred to physical therapy and less likely to fall through on that referral. And we talked about sort of that two-sided mistrust, right? That over time, if you're treated poorly, you're less likely to buy into even the things that we know can sometimes be helpful in managing pain, including physical therapy. So it may not be the only thing that is being suggested, but certainly PT can be helpful in a lot of different conditions, including chronic lower back pain. Some other tools for pain management: TENS unit, heating pads, medications, spinal implants, injections. So even just starting with what's been your experience working with a pain management doctor, or what are your thoughts about procedures to help with pain, to see if that might be helpful. Buprenorphine, so he's on 16 milligrams a day, would temporarily, while he's in sort of more acute pain flare, would switching to a twice a day, or even sometimes a 3 times a day dose of a similar or slightly higher dose be helpful, right? So, 8 milligrams twice a day or 6 milligrams 3 times a day, which would only be a bump up to 18 milligrams, but still might be helpful, right? Some of the issues that with that Matt L already talked about, right? Where, from a regulatory standpoint, we have to be careful with how we're documenting that. I would basically send in the script for 60 milligrams a day and tell the patient to take it twice, the 1 tab twice a day. But that is something that can certainly be helpful. And then setting expectations, right? Jean mentions trial and error, right? But we don't want people to feel like they're being experimented on. And so the way that we get around that is really setting clear expectations of, this is when we'll follow back up. This is when we'll reassess and see if this is working. This is how long it will take before I expect you to see a difference with this new medication that we might be trying. So having those clear expectations and shortening the time to follow up to make sure that we're picking up on any small improvements or improved functioning can be really helpful here. Okay, let's do one more case. So PJ is a 52-year-old female with opioid use disorder and chronic abdominal pain. She's struggling to get answers from her doctors about her pain. She's receiving 120 milligrams of methadone daily through her methadone clinic, but has started drinking to help manage her pain. So what are some questions that we might ask this client or patient, and maybe a suggestion that you might have for helping them manage their pain? So Dustin, Keith, I like that of how long ago did you start drinking to help manage your pain? Like trying to get a better understanding of when the alcohol came into the picture, what particular issue with pain might have triggered it, right? Was it the pain was getting in the way of sleep, and so we started drinking right before going to bed to just sort of numb that pain a little bit? Jenny, that's so important, right? Do you have a diagnosis for your abdominal pain? Has anyone told you what they think is going on, right? And if not, like, we need to get some answers for that, right? Do we need to get you in with a GI doctor or a urologist if it's more of a bladder pain issue? Can you help sort of get her in for an appointment to get that set up? I think that's a really good idea, right? This is someone who's struggled to get some answers. We're not sure if she's seen specialists to try to understand what's going on with her pain. And alcohol has the potential to exacerbate some GI pain by causing inflammation in the belly and the intestine, and even some bleeding issues as well. So I think doing a little bit of education around that. I think that one of my biggest concerns here is that the drinking might it might impact her ability to stay in treatment, right? If she's blowing positive on that breathalyzer for more than a few days in a row at the opioid treatment program, they might step down her methadone dose or even think about tapering her off of it. And so really trying to have a conversation about the drinking and can we de-escalate that so that we don't jeopardize the hard work that she's done to get into long-term remission on the methadone. So I think those are really important points that you guys put out there. Is she needs some answers. Let's try to facilitate getting her to doctors and appointments that might be helpful in getting those answers. But in the acute setting, let's try to address the drinking in a understanding and empathetic way, but with that clear goal of keeping her in treatment for opioid use disorder.